Okay, everybody, this is part 2 of my autonomic nervous system, like mini masterclass to give you guys a taste of what it is that I teach and do and provide in my programs and in my coaching sessions, study sessions, whatever you want to call them. So if you didn't see part 1, I would definitely go check that out as I give a big overall umbrella of the complete peripheral nervous system. Okay. So now let's get into the fun stuff. Let's talk about the giving anesthesia part and kind of put everything together. I don't think I ever really had a good I kind of I understood all the moving parts, but I never really quite put it together until I got out of school and into practice and really saw all this like autonomic issues. And I was like, oh my God, it's starting to all come together and it's starting to all make sense, right? So much stuff is going to click after school, by the way. Like you're not going to be like perfect. You're going to be like damn good when you graduate. But like a lot of stuff just needs time to click and settle in. So this is one of those big things for me that kind of took over time to really see how this plays out under anesthesia. So I wanted to put it together for you guys right here. And essentially, how do we take care of patients with autonomic failure under anesthesia? Because literally we are doing this all the time. Okay. So I want to give you a couple pearls and some gems to bring with you into the operating room. Plus, this is also great to discuss with your preceptors. Okay. So big picture, I'm always going to do big picture and then we're going to break it down. Okay. Big picture thing. Autonomic nervous system is always going to be trying to get your body into homeostasis. That is its job. It has a bunch of reflex arcs, baroreceptor reflexes and all that. I just did a masterclass on that in my coaching program actually last night from the day I'm recording this. But anyways, the system wants balance. Your body wants balance. It wants hemostasis. And that is essentially what the autonomic nervous system is doing. Now, when your patients are undergoing surgery, we are disrupting this. Okay, right? Surgery is going to disrupt homeostasis. Our anesthetics are going to depress a lot of the reflexes and depress the body. So guess what? Our job as a nurse anesthetist, the anesthesia provider, is to become the patient's autonomic nervous system. That is now our job, focusing on perfusion and oxygenation so that their body can still work in a good state while it is being disrupted and depressed from surgery and anesthesia. Okay. So just something to think about. All right. So big picture, what does the autonomic nervous system do? Like what in broad terms does it do? It's responsible for perfusion. It's responsible for autoregulation, which is essentially making sure that if the perfusion pressure drops in the body, the organs, the heart, the brain, the kidney will still have mechanisms in place to ensure they get enough blood flow, to make sure they get perfused. Okay. So autoregulation, perfusion pressure. Okay. That is what we are maintaining and doing while our patients are under anesthesia, because that is what the ANS is doing for me and you right here, right now, living our lives, right? Sweating and shivering is responsible for that. Nutrients, pooping, moving things through your gut, rest and digest, right? Autonomic nervous system. Peeing, urination, and then eye movement and lacrimation. So I want you to think about if this is the big things that this system is doing when we have dysfunction somewhere, this is going to be what is affected. Okay. And when you understand the receptors and the anticholinergics and everything I touched on in the last video, this is all going to come together nicely in your, I know, overwhelmed brains. Okay. Talk about which diagnoses and which drugs. So whenever you see these diagnoses or whenever you see these medications, you're going to be like, oh, okay, this patient has autonomic dysfunction, right? AD, autonomic failure, dysfunction, whatever you want to call it. And then we'll talk about some of the interventions, some of the things to kind of think about, okay? Your diabetic patients, we already know that, right? Autonomic neuropathies, gastroparesis, et cetera. There's different autonomic things that they could have. So your diabetic patients. Patients with chronic liver disease tend to have a lot of autonomic dysfunction. Patients on chemo or recently been on chemo. Patients with brain tumors. This autoimmune stuff, really big for autonomic dysfunction. Guillain-Barré, Eaton-Lambert, rheumatoid arthritis patients, patients that have Sjogren's syndrome, dementia patients, Parkinson's, erectile dysfunction, POTS. You ever seen like POTS? I've seen POTS like so much lately. It's postural tachycardia syndrome, but is like another type of autonomic dysfunction, right? POTS. Okay. And then medication. So if you see these medications, right, you have a med list. They're on pyridostigmine, which we talked about that in the last video. EPO, erythropoietin. They're on a bunch of constipation medications, right? And remember, go back. What does the autonomic nervous system do? Why would they be taking these medications if they have dysfunction, right? That's how you're supposed to be thinking, putting everything together for yourself. Patients on fludrocortisone, which is a synthetic mineral corticoid, and patients that have POTS syndrome will sometimes be on this because it helps augment their intravascular volume and actually help them with their symptom relief. And then Mediodrine. All right, I want to sidebar with Mediodrine really quick, and I would love to hear what you guys do at your facility or what you have seen. But essentially, I see Mediodrine fairly recently, which is why I kind of started going down the rabbit hole of looking into POTS and Mediodrine and all of this, because I was just seeing it so much and I didn't know if I was quite managing it the best way, that I knew how, which once again, guys, that's a job. You're not going to know everything, but as everything, you are capable of figuring anything out. And that is why it's so important to ask questions and to watch and observe and to dive deep, because there's just so much to know and so much richness, and you can learn from so many people, even the ones that you don't really like. Okay. They usually will teach you the most. Anyways, sidebar. So Mediodrine is basically a alpha-1 agonist, and it is given because the number one symptom thing that you are going to see in patients that have autonomic dysfunction is either going to be syncope or orthostatic hypotension. That is like literally like ding, 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 like you have autonomic dysfunction. Okay. So what they'll do is they'll put these patients on Mediodrine, and it essentially is alpha-1 agonist, which is, we know alpha-1 is a constrictor, phenylephrine, right? Alpha-1 agonist constricts blood pressures, constricts blood vessels and brings the blood pressure up, okay? So you will see patients on this who have hypotension. Oh, I have hypotension. They put me on Mediodrine, okay? So the thing is, it works in about 30 minutes. So it's onset in 30 minutes. It usually lasts for about 4 to 5 hours. So the question is, do we want our patients to take this prior to surgery? Now, you would think yes, because what do anesthetics do? Vasodilate everything, right? We're depressing and we're vasodilating. So you would be like, yeah, I think I want to give that because then it will help keep their blood pressure up. I cannot find any clear anything in the literature that says whatever, because very rarely is our jobs black and white and cookie cutter or whatever. But what I did was reading that one of the adverse effects is that when these patients lay supine, they can actually get really hypertensive. So they even say they don't like you're not supposed to take this medication within a couple hours of bedtime, because apparently your blood pressure can get like 180s over 100 if you take this medication and lie flat. So I was just kind of thinking, and I also found an study that said that some people were giving prophylactic 10 milligrams of Mediodrine before spinal anesthesia, and it was preventing hypotension. So just throw that out there. I don't do that. I don't know anyone that does that, but I'm like, just the things you find when I'm like looking for stuff. So anyways, so my thing is like with anything, okay, like if you have a patient coming down, they take Mediodrine. First of all, like what are they here for? What is their current state of their comorbidities? Are they really acutely sick? Like, where are they at? What is their blood pressure, right? What is their blood pressure sitting up? What is their blood pressure laying down? If you want to have the nurses check that, or check that when they come down. So looking at that piece, what is the surgical position going to be in? Because they say if you change their position, you actually will fix the blood pressure, because I guess their blood pressure is very dependent on their position, these patients, okay? So I would just look at all those things. What is the blood pressure? What position is the surgery going to be in? How long is the surgery going to be? And honestly, like if it's an alpha-1 agonist, you can fix their blood pressure with Neo on there. Do you really want something else in the mix? I don't know. It can go either way. So I'd love to hear your guys' thoughts, what you guys have seen, because that's how we all learn. But that is just kind of how I was approaching this. So now that you know what patients to kind of look for that will have autonomic dysfunction and issues, what are the issues that they may have that you might see under anesthesia, and what can we do to, really take excellent care of them and to mitigate some of these things that are happening? Okay. So let's go from head to toe. So first of all, with their airway, they might have very poor joint mobility. Okay. So just make sure you're checking their like extension, of their neck, looking at their mouth opening, stuff like that, because they might potentially be difficult to intubate. So you might want to think about getting a glide scope, etc. Okay. So airway is one of the things. Now, as far as their heart goes, a lot of them will have like a resting tachycardia at baseline. They also might have an impaired baroreceptor function, okay? And baroreceptor is essentially what responds to blood pressure changes in the body. If the blood pressure goes up or the blood pressure goes down, the body responds to that. This baroreceptor is not going to be working properly. So what does that mean for you? Essentially, you are going to be on a roller coaster ride of lability with their blood pressures. Any autonomic patient they're going to be very sensitive to pressors, very sensitive to the medications potentially, and they might just go up and down. Their blood pressures all the way up. You intubate them and you're like 190. And then all of a sudden you put the gases on and they literally swing to like 60, like those big swings. That's a sign of autonomic dysfunction in patients. They're also more at risk for dysrhythmias and MIs, okay? Because of the ischemic damage that can occur when you're on literally a roller coaster ride. So making sure they're very deep, a nice, deliberate, slow induction. You might think about wanting to wake them up kind of deep, depending on other things, stuff like that. If these patients go bradycardic, they might not respond to atropine. Their vagal tone is already going to be very diminished, so they might not respond to atropine. So you might want to think about isopril, temporary pacemaker. Once again, I've never seen this, but hey, you never know. I've seen some crazy things, right? And like I said before, a lot of our adrenergic medications could they could be a little resistant to them, or they could be very, very sensitive to them as well. And you might get like an exaggerated effect. So always dose them low. The best drugs, since midodrines and alpha-1 agonist, is phenylephrine and ephedrine. Those are our two go-to anyways. That was what I would stick to. I would just literally like third or cut the dose in half, just give them a little bit because it might go a long way. And they could also be resistant to it too. So you might be thinking about potentially higher levels of care depending on, or higher levels of management depending on, the surgery and like what else is going on. Okay. They also, patients that have autonomic failure might not be able to increase their cardiac output through sympathetic nervous system activation as well. So they could be very sensitive to positive pressure ventilation, right? Any type of issue with getting venous return back, right? Like, so you're thinking of all the dynamics at play here. They might not be tolerant to that. Pneumoperitoneum, laparoscopic surgery, right? They might be super sensitive or not tolerant of these things, okay? Because they don't have the autonomic system to back up and the reflexes to back up what they need. So you might potentially, with laparoscopic surgery, maybe using smaller tidal volumes. And then we'll talk about in a second with like IV fluids or whatever. Because a lot of what, even when I was reading about the POTS, postural tachycardia patients, they tend to get very hypotensive intra-op. So just something to think about. Think of all the things that are at play besides just your anesthetics, okay? I didn't put this on here, but anemia, they might be anemic. So just another thing to think about. Now, as far as IV fluids, we want to just maintain euvolemia as best we can. We also might want to volume load them before surgery or before maybe giving regional. I did find an article that talked about, doing spinals in these patients. And essentially what it came down to is that deciding between regional and general anesthesia is not really that important. What's important is adequate volume replacement and hemodynamic monitoring. So volume load them up front, so you have a little bit of wiggle room, and potentially you might want to think about an A-line depending on the length of the case, the patient, stuff like that. So just things that you want to be thinking about. But if they lose a lot of blood volume very quickly in surgery, if you also load them way too fast with like 2 liters up front, like they cannot handle that, right? So you want to be very careful. You want to do everything very deliberately, chill, slow with these patients. Okay. That's what I say about that. Lungs. So these patients at baseline, they actually can modulate or control their blood pressure with manipulating, their body will manipulate their minute ventilation. Minute ventilation is tidal volume times respiratory rate. Okay. So essentially, if they're hyperventilating and they're hypocarbic, right, it will actually cause a fall in their blood pressure. Okay. Conversely, if they are hypoventilating and they've got more CO2 on board, they're hypercapnic, it can actually increase their blood pressure. Okay, that's kind of like at baseline. All right. How this relates to anesthesia is they have impaired central regulation of their respiration. Okay. And this can actually be aggravated post-operatively. I mean, intraoperatively too, but you want them to have very close monitoring post-op as well. Okay. Because they will have a lot of sensitivity on their respiratory. Their respiratory center is already messed up. So they're going to have even more sensitivity to that with opioids, with your anesthetic agents, all that stuff like that. And then patients that go apnea and can have like basically a buildup of hypercapnia, right? They can get this excessive rise in blood pressure. Okay, so once again, very labile, very up and down, and their minute ventilation can have a big effect on their blood pressure. Okay, so just something to think about when you're titrating your opioids and your anesthetics. I said the big thing with them is the orthostatic hypotension. So they also will be very sensitive to position changes, but they also respond very well to position changes. So essentially putting the head down and trying to help with the hypotension that way, or very slowly putting their head up, things like that can help kind of change your blood pressure situation with them. Be very careful with these patients who are in beach chair, because due to their varying set points, if they have hypertension as another diagnosis, if they're like a diabetic and they've got, autonomic dysfunction, they are going to need more of a pressure to get that blood up to the brain. So something to think about. Okay. Temperature wise, so they can essentially lose the ability to sweat, which in turn can make you hold on to like more heat and get hot. However, when we're in the operating room, right, it's freezing cold, right? These patients also cannot vasoconstrict in response to a cold environment. Okay. So they can have excessive heat loss, which, if our patients are cold, they can be coagulopathy with that. They can hold on to the anesthetics longer. Risk of infection goes up. So long story short, just warm them up with a bear hugger. Okay. And watch their temp closely. All right. Maybe do like a nasopharyngeal. You don't have to do like an esophageal, but maybe a nasopharyngeal temp or something a little more centrally to watch their temp. Okay. And this is especially true in your diabetic patients. So if I have a diabetic patient, especially if they're older, I don't care what, I wrap their head. I always try to warm them up, but also keep them warm, but also monitor their temp as well. GI wise, like I said before, they might have gastroparesis. They might have some dysphagia, decreased GI motility. You want to be getting OG tubes, in them if you're intubating them. Thinking about LMA versus tube, depending on the surgery. There's so many other factors, but depending on things, just have to think about dysphagia. So aspiration risk, all the stuff like that, getting Pepsid on board, all the things, more stuff to think about. GU, kidney and bladder, they might have renal dysfunction. So paying attention to that, hence why they're on like EPO as well. Urinary retention. So think of like our drugs and how our drugs can also contribute to not being able to pee or poop and stuff like that. Could be even worse in these patients. Okay. So something to think about as well. These patients will also, like I said earlier, will have they might have erectile dysfunction as well. That's a sign of autonomic dysfunction. So being on those medications, like I said, I did a video on that before. So just stuff to think about. Now, these patients that have this autonomic dysfunction or POTS, they actually, like their doctors will actually prescribe them abdominal binders and compression stockings. So get a compression stocking on them. If you're having really bad hypotension, get creative depending on the surgery. Wrap an abdominal binder on them. See if you can get that pressure up, change your position, right? So many things to think about and do. And be really careful with Valsalva, like if they're vented, because they can have an extreme response of blood pressure to the Valsalva maneuver, because you're essentially increasing intrathoracic pressure, dropping venous return, cardiac output, all that good stuff. So they might not like that and respond to that. Okay. So I hope this is helpful, but there essentially is your autonomic nervous system in 2 videos, breaking everything down for you. And then this is kind of the side of what patients would you expect to have these issues. So what diagnoses and medications are going to be like, oh, okay, let me see, like, this is going to alert me to start thinking of these things. And then, you know, tailoring your anesthetic based on the other issues they have, based on other comorbidities, based on the type of surgery, et cetera. Like, this is the job, right? And this is why you have to work so hard before, during, and, you know, after school too. You know, I don't work quite as hard after school, but you know what I mean? Like, you're continually learning, you're continually thinking about things from all type of angles. And that is essentially how you give anesthesia and take excellent care of your patients. So I will see you guys in the next video. Bye.